Patrick Commiskey here in Albuquerque, New Mexico. This is a secondary lens for a patient who is aphakic, has no lens in their eye. I believe this was after a vitrectomy, lensectomy, or after a complicated cataract surgery that left the patient aphakic, so then they come to us to sew in a new lens. I always start with a subtenon block. I love it compared to retrobulbar block. I think it's safer and just as effective in all the ways that matter for this type of surgery. I sort of set myself up for in the conjunctival peritomies, opening the conjunctiva, doing a little bit of light cautery. A little bit of oozing is okay, and it helps seal the wounds. I sort of set everything up at the beginning of the case, put the trocar in, make the scleral tunnel here with the spoon blade. And I sort of tunnel into the clear cornea from the scleral. This provides a stable wound. Use a 2.2 millimeter keratome that we use for cataract surgery. Enlarge the wound to about 7 millimeters. There's so many techniques for secondary suturing of lenses. And this is the one that we prefer. So there I removed the last little bit of residual cortex and kind of summering type of material there. We try to get all of the residual lens material and capsular bag out so that there's less material to fibrose to our lens, to the iris. We also make sure to do good vitrectomy. Even a patient that's already had a Pars Plana Vitrectomy, there may still be a little bit of residual anterior hyaloid that is behind the iris, so we're careful to remove all of that. Here we have our Gore-Tex suture that's kind of ready to go. I hand it to myself inside the eye and hand off the other one too. Oh, a little bit of, hey, where's that little incision? A little bit of blood in the way. Okay, there we go. So I'll get the lens inside the eye. Looks like the patient moved a little bit at a funky time, but we're just kind of cruising along. I'm just going to loosely tie that side so that it stays in place. And then we'll go ahead with the second side of the lens. This technique was really developed and elaborated by Greg Ogawa, fantastic complex anterior segment cornea surgeon here at Eye Associates that I've had the pleasure to work with. So this is his technique, and I love it. Like I was saying, there's many techniques to secondary suture lenses. I've kind of done all of them, all the major flavors of techniques, and this technique lasts a little bit longer. There is the larger incision. Um, even with good architecture, it's still a larger incision superiorly. Um, but other than that, we do not see these patients come back with issues, related to the technique of the surgery. There's some things just, these eyes tend to be more complicated. They have a higher probability of developing a retinal tear. Even if we don't see one, before surgery, there's a higher risk of a retinal tear. And but we're really not seeing complications related to the technique of the surgery itself. And so, with that, I'm not highly motivated to um, change the technique. Uh, we have a lot of patients that come from far, far away, and we try to make them one and done. This is the one surgery they have for their sutured lens, and we try to leave it at that. We just used our 10-0 nylon to um, close up that superior scleral tunnel. Here I'm making some peripheral iridotomies, two peripheral iridotomies to prevent reverse pupillary block. I think this is important to do, regardless of your technique, to avoid that issue of the fluidics inside the eye, causing a trampolining of the lens. So here we're bearing the knots. Every now and then one of the knots breaks on bearing, so we got to rethrow a knot. Here we're fully bearing the Gore-Tex knot inside the eye. It's a tight incision, purposefully so, but we are fully bearing the knot inside the eye to prevent any extrusion and erosion through the conjunctiva, melting in the sclera itself. So the knot goes all the way inside the eye into the ciliary body, where in our experience it just fibroses into place. We're using 10-0 Vicryl to close the conjunctiva. It is the most annoying suture because it's so small you can barely see the thing, but it's the most comfortable for the patients, and I think gets the job done. So that's overview of our scleral suturing technique. I made it 4 times speed, just so we could get through it. But happy to talk at length about this technique. Really enjoy doing these very rewarding cases. We always leave a little bubble at the end and inject some medicine. Thanks for watching.